The 1918 influenza pandemic lasted about a year and a half, and we are already a year into the current COVID-19 pandemic. A preliminary comparison of the 1918 H1N1 influenza and COVID-19 pandemics with a focus on the Canadian COVID-19 preparedness and response plan, execution, and the populace perception and reaction is presented in this video. I left my laboratory technologist job at a local hospital on January 12th of 2020 to focus on education. At that time, there was no sign of COVID-19 in Canada, at least. However, China had already informed the World Health Organization about a cluster of 41 people exhibiting a pneumonia-like illness on December 31st, 2019. By January 1st, 2020, experts connect most cases to the Wuhan wholesale seafood market, which results in its shutdown. I met my lovely colleagues, seniors, and manager again at a farewell dinner party they arranged for me on March 6th. I was concerned about them due to possible COVID-19 patient admissions, but they informed me that at that point, there were no cases at their hospital. Torrent statistics reveal a spike in downloading and streaming of outbreak and pandemic-related movies during January, particularly in South Korea. At first, these movies are not available via major streaming platforms such as Netflix, Amazon Prime, or Hulu. By mid-March, Contagion is available on Netflix Canada and soars to the #1 spot. Other pandemic-related documentaries are also either added to the lineup or showed up on the recommended list, most likely due to Netflix A/B tests. I mention these movies' consumption because they, along with news available through the internet, significantly influence the populace's perception and inform their choices. In this case, the fascinating fact is that people were going out of their way to watch these movies as they were paying to watch before they were available on major streaming sites. Could they have been seeking knowledge about a deadly new virus through these movies because expert information was not available or easily accessible? As news about the new virus and resulting deaths in China and Europe disseminated widely, panic ensued and people worldwide began to stockpile items. Damer 2020 explains that such stockpiling of goods is potentially economically and socially disruptive. Damer 2020 suggests that the stockpilers may possess higher neuroticism scores and have a lower ability to cope in a crisis. Furthermore, individuals who score low on an agreeableness scale tend to significantly focus on their own needs rather than exhibiting cooperative and altruistic behaviors. By the time I got to the grocery store, there was no toilet paper or sanitizing wipes left. In fact, my local grocery store and drugstores still do not have any sanitizing wipes in stock. A H1N1 influenza virus caused the most severe pandemic in recent times. Occurring in 1918 with avian origins, avian meaning birds, its course ran almost parallel to that of World War I. Initially, as influenza virus spread across nations, it was being dismissed as a common seasonal flu due to it causing too few fatalities. However, influenza first caught global attention that year when it gripped Spain's king. And because the country was not participating in the war, its newspapers wrote freely about the illness in great detail. In contrast, other countries like the US were more concerned about their war efforts. To maintain high morale, they deliberately lied and withheld information from their citizens about the virus's actual effects. It is estimated that about 500 million people, or 1/3 of the world's population, became infected with the virus. Overall, the most damaging pandemic of influenza known by humanity killed between 20 to 100 million people, including 50,000 Canadians. Worldwide, the socially and economically disadvantaged were affected far more significantly by the influenza pandemic. In Canada, a higher proportion, about 3% of the Indigenous population, was killed by the ravaging influenza virus. Although historians concur that this strain of the H1N1 influenza virus was first observed and started to spread in March of 1918 and new cases significantly reduced by February of 1919, there were cases still present in Europe in April of 1919. A unique feature of the 1918 influenza pandemic was its high mortality rate in healthy people, including individuals in the 20 to 40 year age group. Targeted pharmaceuticals, antibiotics, or vaccines had not been developed yet to treat severe symptoms and secondary pneumonia infections or to prevent the influenza infection in the first place. Therefore, interventions such as isolation, quarantine, good personal hygiene, use of disinfectants, limitation of public gatherings, and mask wearing were used to contain and prevent further spread of the H1N1 virus. Despite being studied at length, much about the 1918 H1N1 virus's mechanism of action, which caused immense devastation that still terrifies scientists, historians, and anyone who investigates it, remains a mystery. Historians also highlight the shortage of healthcare workers, primarily nurses, during the pandemic period. Infected physicians, nurses, and other healthcare workers were not being replaced. Extensive efforts to recruit and train new nurses still not lead to sufficient enrollments. Berry 2017 pieced together evidence that indicates that the 1918 H1N1 influenza pandemic could have actually started in the United States. He explains how Haskell County in Kansas is a major migratory flyway for 17 bird species, and its farmers also raise hogs. Scientists now understand that bird influenza viruses, like human influenza viruses, can infect hogs. When a bird and human virus both infect the same pig cell, their different genes can then combine and possibly form a new and lethal virus. This community, the rest of the United States, and the world were used to seeing seasonal influenza cases, which primarily affected the upper respiratory tract, producing symptoms of a cold, sore throat, cough, and fever, and lasted for 3 days. Occasionally, this influenza also had led to secondary diseases of bacterial pneumonia. However, the 1918 physicians and scientists did not know yet that influenza was caused by a virus and not a bacterium. Influenza outbreaks within civilian communities and deployed soldiers, despite producing severe threatening symptoms, were being dismissed as regular la grippe, an older French term for the flu. The initial or first wave of grievously affected soldiers were also misdiagnosed with meningitis. Additionally, unreported cases in local communities and misinformation by authorities about the pandemic being of a mild type and near its end led to the continual spread and proliferation of the H1N1 influenza virus. It was not until the pandemic's deadly second wave in September of 1918 that officials require all flu cases to be isolated at home or a city hospital. By then, the H1N1 virus had caused widespread devastation and killed an estimated 195,000 Americans. People were scared as they witnessed or expected horrific symptoms such as cyanosis due to blood's deficient oxygenation, and foamy blood coughed up from the lungs and bleeding from the nose, ears, and eyes. In contrast, physicians, scientists, and researchers believe that some people who are affected by the COVID-19 virus to a great extent may possess an immune system that is unable to shut off, leading to an accumulation of cytokines and an abnormal amount of inflammation, which has been termed cytokine storm. Cytokines are important messengers, part of our normal protective immune response system. But in COVID-19, the exaggerated immune response, they aid damages normal cells, tissues, organs, and causes blood clots. Physicians concur that majority of the COVID-19 positive patients died after developing acute respiratory distress syndrome. So we do see some similarities between the two pandemics, but there are also a significant amount of differences. Here are timelines of both the pandemics, highlighting the most important associated events. During the 1918 influenza pandemic, in April of 1917, the U.S. enters World War I with 375,000 soldiers. In March of 1918, re-recruits are trained at large camps near Haskell County, Barnes, in Kansas, each housing up to 55,000 soldiers. A large number of soldiers at Camp Funston in Fort Riley, Kansas, then become ill with the flu. By April, a public health report detailing 18 severe cases and 3 deaths from influenza-like illness in Haskell County, Kansas, becomes the first publication about the ensuing pandemic. By May, thousands of U.S. soldiers travel across the Atlantic as they are deployed for World War I. By September, the second wave is highly fatal and responsible for most of the deaths attributed to the pandemic. New York City's Board of Health adds flu to the list of reportable diseases and requires all flu cases to be isolated at home or city hospital. More than 14,000 flu cases are reported at Cape Devens, resulting in 757 deaths. By October, the virus kills an estimated 195,000 Americans, and the United States experiences a severe shortage of professional nurses because of the deployment of many nurses to military camps in the United States and abroad. By November, World War I ends, and it prompts a resurgence of influenza as people celebrate and soldiers begin to demobilize. Salt Lake City officials place quarantine signs on the doors of 2,000 homes where occupants have been struck with flu. By December, public health officials begin education programs about the virus's spread and prevention measures. Non-essential outings and businesses are encouraged to close, and staggered work hours are implemented. The public is required to bike or walk to work instead of using public transport. By January of 1919, a third wave of influenza begins and lasts until the spring of 1919, killing many more. Trustees of the Boston City Hospital asked the mayor to fund influenza treatment study. By February, number of influenza cases began to drop in the U.S. Recruitment and rapid training of nurses occurs to address massive shortages. By April of 1919, U.S. President Woodrow Wilson collapses at Versailles Peace Conference while negotiating the end of World War I with other world leaders. Historians speculate he had influenza, which was still present in higher numbers in Paris. During the current COVID-19 pandemic, on December 31, 2019, China informs the WHO of a cluster of 41 patients with mysterious pneumonia-like illness. By January 1, 2020, Wuhan seafood wholesale market closes after it's determined that most cases are linked to it. By January 23rd, the city of Wuhan is placed under quarantine, and a few days later, so is the entire province of Hubei. By February 7th, a whistleblower, Dr. Lai Wenliang, a 34-year-old ophthalmologist who first warned of the new virus and was reprimanded by Chinese authorities as a result, dies from it. By February 19, Iran's outbreak begins. Within 6 days, the country's deputy minister, Dr. Iraj Harashai, will appear ill in a press conference and later test positive for the virus. By February 20th, South Korea surpasses 100 confirmed cases. After taking strict measures to contain the virus, South Korea's daily new case count begins to decline after peaking at 851. By March 9th, Italy locks down its entire population, restricting movement across the nation. Its confirmed case count hits 9,000. By March 11th, the WHO declares a pandemic. The global confirmed case count at this point is 126,000. By March 24th, India implements 21-day mandatory lockdown. By March 26th, the US becomes the nation with the most infections globally, surpassing 100,000 cases within 24 hours. By March 27, Italy reports more than 900 deaths in a single day, the most of any country since the virus emerged. By March 30th, Spain reports more than 900 deaths in a single day, and the US reports the same the following day. On April 10th, cases surge in Russia, and the number of hospitalized people double from the previous week. By April 24th, the European Union is pressured by China, its vital trading partner, to change some of its report on COVID-19 to take the focus away from the full extent of China's role. By May 17th, Japan and China, two of the world's largest economies, enter recessions. By May 22, Brazil overtook Russia in reporting the second highest count of infections worldwide, reaching more than 330,000. US remains the global epicenter with more than 1.6 million cases and the number of deaths nearing 100,000. By June 30th, the EU says it would reopen borders after pressures from tourism industry. Australia, Canada, and New Zealand were among the approved list of countries, while travelers from China will be permitted if China reciprocates. By July 10th, Hong Kong shuts down schools as new cases are creeping up amid a third wave. August 9, 2020, 100 days since the last positive case of COVID-19 in New Zealand. In the months to come, the country encounters community outbreaks and measures are swiftly put in place to contain them. By August 10, the CDC begins developing a plan to distribute vaccines, its largest ever campaign. By September 1st, universities and schools that open move all classes online. In Canada, there are 2 options in most provinces, online or on-site, and students stay and learn within their small cohorts throughout the day. Symptoms are checked daily, and ill students are to stay at home for 14 days. By September 28, the global death toll reaches 1 million. By November 5th, England enters national lockdown. Several world leaders have tested positive for the virus by this point, and nations are struggling to curb its spread. By November 13th, the CDC reports that increased number of children are visiting and being admitted to hospital mental health wards. By November 21st, the FDA granted emergency authorization of the coronavirus antibody treatment given to President Trump. By December 2nd, Britain gave emergency authorization to Pfizer coronavirus vaccine, becoming the first Western country to allow mass inoculations, and vaccinations begin days after. By December 11th, the FDA authorized Pfizer COVID-19 vaccine for emergency use in the United States. The same vaccine was also approved by Mexico, Canada, Saudi Arabia, and other countries. By December 18th, the FDA authorized the COVID-19 vaccine by Moderna for emergency use, allowing the shipment of millions more doses across the US and other nations. By December 20th, concerned by a new, faster-spreading variant of the coronavirus, Prime Minister Boris Johnson imposes a strict lockdown on London and most of England's southeast. Countries across Europe and beyond began closing their borders to travelers from the UK. By December 27, Canada's largest province of Ontario enters a 24-day lockdown on midnight of November 27 after Boxing Day. We can roughly graph the government and expert preparedness and response plan in action during the 1918 influenza pandemic and the current COVID-19 pandemic. Although we can gather a good amount of accurate information about the current pandemic, the information on the 1918 influenza pandemic is discontinuous and may not be entirely accurate. However, it can give researchers an idea of the information that is available on the topic and whether their hypothesis about such a comparison can be correct, or it could reveal new information such as other independent variables causing an effect on their dependent variable. Here we choose the measures implemented by the authorities according to Ontario's 5 color-coded levels and plot it against the months for both eras, 1918 and 2020. Here we can see that the COVID-19 preparedness and response plan is better than the one in 1918 to 1919. Also, when we compare the number of cases and deaths, they are lower for COVID-19. However, there are many other factors to consider here, and we cannot simply say that the preparedness and response plan is better, therefore less cases and deaths occurred. The virus is not the same, and it could be that the 1918 H1N1 virus was more virulent. Also, the scientific advances that we are privy to today were not available a century ago. Scientists were just scratching the surface in terms of virus research. But should we have expected an even better result from the advanced COVID-19 preparedness and response plan? We have far more information on our fingertips about the COVID-19 than anyone had about the influenza a century ago during the influenza pandemic. But misinformation is also quite rampant on the internet. Therefore, along with guidance from experts, we should learn about reliable sources to turn to for more accurate and timely information. The WHO, CDC, and public health websites in their respective countries are doing an excellent job of openly providing up-to-date information about COVID-19. This Government of Canada website provides updated data and statistical analysis on the number of cases and deaths worldwide. It also gives more details about the Canadian populace, such as the number of of people tested. So what did we learn from the past pandemic and the current one we are still in throes of? Most developed nations had a solid WHO-approved preparedness and response plan. However, the implementation of these plans was poor. Just as in 1918 to 1919, the public is looking for information and direction. They expect their nation's leaders and experts to provide them with relevant and accurate information. They are more than willing to follow the guidelines implemented by the authorities, but the switch back and forth from strict measures to looser ones and then back to stricter ones again is confusing. Therefore, our leaders need to decide what is more important, economic or human losses. Political matters also took priority in some countries. Just take a look at the US. The election was taking place at the same time as thousands of people were dying in that country. In contrast, in New Zealand, the elections have been put off 3 times to ensure focus on the health and safety of the citizens. Other nations should take lesson from countries like New Zealand. The Prime Minister of New Zealand, Jacinda Ardern, has said that she, along with the experts in her country, looked at the ICU capacities at the very beginning of the outbreaks worldwide and decided that stringent measures such as lockdowns, including business and border closures and travel bans, were necessary for them to prevent cases, which would have otherwise surely overwhelmed their hospitals. Professor Michael Baker, an epidemiologist at the University of Otago, had this to say about the New Zealand and other nations' COVID-19 plan. It was good science and great political leadership that made the difference. If you look around the globe at countries that have done well, it's usually that combination.